Greetings, everybody. Welcome to our sixth and final session of the Pediatric Roundtable series with the Lurie Children's Center for Cancer and Blood Disorders. We are here today with Dr. Rukhmi Bhat, and she is going to tell us about blood clots in children and adolescents. My name is Chad Worley. I am your Lurie Children's physician liaison for the city north and northwest suburbs. I'm joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. Before we move on, I would like to tell you a little bit about the Center for Cancer and Blood Disorders at Lurie Children's. We treat more children with cancer and blood disorders than any other hospital in Illinois. Although cancer is rare in children, we do treat 220 new patients each year with a wide range of childhood cancers. We are ranked nationally and #1 in the state of Illinois by U.S. News and World Report for pediatric oncology. We have locations in Arlington Heights, in Lake Forest, at Central DuPage Hospital, the Northwestern Medicine Proton Center in Warrenville, New Lenox, Northbrook, Westchester, and of course, our main hospital in downtown Chicago. Dr. Bhat, our host today, has pediatric interest in pediatric thrombosis, general hematology, neonatal hematology. She sees patients downtown in Arlington Heights at the Bussey Center and Lake Forest, Northbrook. Now, before I turn it over to you, Dr. Bhat, I just want to remind everybody that we record these sessions and we encourage your questions. So please engage with us. We know she's going to have some stuff that you want to ask questions. Just go ahead and type them into the Q&A section, or at the end of the session, if you want us to ask your question live, just hit the raise your hand icon and we will go ahead and call on you live. But without further ado, Dr. Bhat, go ahead and take over the screen. I'll stop sharing, and we look forward to hearing your presentation today.
All right, I'm going to start showing my screen. Are you, just a quick check, Chad, are you able to see my screen? And
we are, but you are not in presentation mode, so you need to go back to presentation mode. There we go. Better? You're all set. Have a good presentation. Oh, we just lost your screen. There we go. All right.
All right, great. Thank you, Chad, for that really nice introduction. And thank you all for joining the webinar series. Today, I will be discussing blood clots in children and adolescents, what the families and the primary care physicians or pediatricians need to know. As Chad introduced myself earlier today, my name is Rukhmi Bhat. I am the thrombosis program director here at Lurie Children's. And my clinical interests as well as research interests are in treatment of blood clots in children and adolescents. So to get the discussion started today, I just put out this outline. I'm going to be reviewing what a blood clot is, or a thrombus. What are the normal body mechanisms that are in place that help us form a blood clot normally? And then in terms of discussion of thrombosis, what are the different types of blood clots we see in children and adolescents? What are some of the risk factors? What is thrombophilia? Explaining both what is genetic thrombophilia as well as acquired thrombophilia, the treatment of blood clots, some of the complications that can occur after a child develops a blood clot, review some prevention tips for preventing future blood clots. And then I'm going to end with some resources for families as well as primary care doctors that they can review with the children as additional resources to have some more information on blood clots. So to get us started, what is really a blood clot or a thrombus? A blood clot is a pathological clot that can occur inside a blood vessel. Now, this blood clot can occur in either an artery or a vein. And for the discussion today, I will focus on venous blood clot. As you can see in the cross section below of the blood vessel, you see a vein and the valve inside of the vein, which helps us helps our body flow blood from the legs or the arms towards the heart to undergo oxygenation. When a blood clot forms, it obstructs this blood vessel, preventing the blood flow, and this can cause problems. And if this is not treated, then there can be other complications that we see. Now, do we really need blood clots? And the answer is yes. What are the normal mechanisms that our body forms blood clots? What you can see here is the cascade model of coagulation. And for the body to trigger this, there is either a break in the vessel wall because of trauma or surgery. Now, this cascade model is an older concept where coagulation proteins were thought to be activated in a stepwise fashion, leading to the formation of a fibrin clot, which is actually a normal blood clot. This prevents our body from losing too much blood. But when there are some genetic mutations or acquired defects, either in these coagulation proteins that are denoted by the Roman numerals you see listed here, or the regulation of these coagulation proteins by what we call as natural blood thinners that are made inside of the body, that can cause a pathological blood clot. The newer model of coagulation tells us that there are some overlapping steps on the surfaces of cells, including platelets, that lead to a normal blood clot from happening. And you can see that these occur in simultaneous steps, which go by the initiation phase, the propagation phase, and the application phase. And all of these mechanisms lead to a normal blood clot from happening. Blood clots can happen in veins that carry blood away from the arms and legs. And you can see that it is depicted in that first picture on the left, which shows that a deep venous thrombosis in the leg. They can also occur in other parts of the body, which includes the liver, the kidney, and the heart. There are clots that can also occur inside of the veins in the lungs, and those are referred to as pulmonary embolism. And unfortunately, blood clots can also occur within the blood vessels in the brain, and these are referred to as cerebral venous sinus thrombosis. So just reviewing the different types of thrombosis, these are referred to commonly as DVTs that occur in the extremities, which are the arm and the leg, the portal vein, which is the liver, renal vein, which is the kidney, and the right atrium, which is the heart. Pulmonary embolism refers to a clot in the lungs, and both these together are commonly referred to as venous thromboembolism. And so for the remainder of the talk, I'm going to use the term called VTE. And then finally, a clot inside of the brain called the cerebral venous sinus thrombosis. Looking at some of the signs and symptoms of VTE, if a DVT occurs in the arm or a leg, it gives rise to sudden pain in that arm or the leg. It can give rise to swelling, tenderness, and redness or warmth of the skin. Sometimes children sort of notice that they are either limping or they're not able to lift their arm or the leg that has the DVT. That brings them to attention. A clot in the lung causes difficulty breathing, chest pain or coughing up of blood, commonly called hemoptysis. A blood clot in the heart can cause a heartbeat to be running fast. So it can cause tachycardia, or it can cause changes in the blood pressure. And a blood clot in the head can lead to lightheadedness or fainting, or another common symptom is headache. Now, how common are blood clots in children? Blood clots happen more commonly in adults than they happen in children. So in children, about 1 in 10,000 children get a blood clot. But this incidence is much higher in children who are in hospitals, and this can be up to 1 child in 200 who get hospitalized for different reasons. The incidence or the epidemiology of pediatric VTE, we've seen that it has changed over times with an increase in the past several decades. And there are many reasons for these. That's because we have made several advances in treating children with chronic blood disorders. or common or chronic medical conditions. And most of the information we get about incidence of blood clots in children and adolescents comes from international registries. Some of the international registries that have reported incidence rates are the Canadian registry, the German registry, the Dutch registry, and the British registry. These registries, as you can see from the dates, the incidence rate reported are kind of in the early 1990s and the early 2000s. And they reported rates of VTE both for venous and arterial blood clots at different in different age groups. What we know from these registries is that there are two common age groups that we see blood clots in children. The first age group that we see is in the newborns or those infants. As you can see in the graph below, you see the highest incidence there. The second age group that we see we see blood clots commonly in is the adolescent population, so the 12 and up until the ages of 18. Now, all of this information about incidence was from registries that were in the 1990s. More recently, there have been reports from the Pediatric Health Information System or from studies that have looked at rates of VTE among hospitalized children, and they sort of reflect the same trends that were seen in the international registry. So if you can look in the upper right-hand corner, there are increased rates of incidence in the newborn population as well as the teenage groups. And this is looking at VTE rates in hospitalized children. You can see that the most rates of blood clots in children are in the less than 1 year, as well as the adolescent age group. Despite all of this, symptomatic VTE is very uncommon in children relative to adults. There are usually multiple risk factors, which we refer to as provoked risk factors that are present in childhood VTE. And there is a very small number of VTE that we refer to as spontaneous blood clots, meaning that they don't have an underlying provoking risk factor, which is a little bit different than what we see in adults, where most of the clots in adults are spontaneous, and some of them are associated with clinical risk factors. Why is that that we see blood clots more commonly in adults than in children? Children have some natural mechanisms that inhibit thrombin, which is the protein that's formed in the blood excessively. It can lead to a pathological blood clot. As compared to adults, the plasma concentration of all of the coagulation factors that we just saw in the coagulation cascade and the newer model of anticoagulation, those plasma concentrations of those coagulation factors and the capacity to generate thrombin or fibrin are decreased throughout childhood. Additionally, children less frequently develop diseases causing damage to the vascular endothelium, such as diabetes, high blood pressure, or disorders of lipid metabolism. Children are also less frequently exposed to acquired prothrombotic risk factors like hormonal pills that have an estrogen component to it, pregnancy, smoking, cancer, surgery, and etc. In 1856, Rudolf Virchow proposed a hypothesis to explain the etiology of pulmonary emboli, which led to the understanding of three primary causes of thrombosis. And these include stasis, injury to the vessel wall, and abnormalities in the circulating blood, also referred to as hypercoagulability. Subsequently, numerous investigators elucidated the concept of a hemostatic balance between fibrin or clot formation and fibrin dissolution. So our current understanding of VTE risk factors are listed here on this slide. If there is a family history of blood clots, either an inherited condition, that increases the clotting risk. If a child is hospitalized for any reason, if there's decreased blood flow, which can often be caused by confinement to the bed, which children are often in the hospital, if there's limited movement, either because of a fracture or surgery, prolonged travel, if there are some long flights that you're sitting for long periods of time, or for any reason you're not able to get out of bed, such as paralysis or stroke. injury to a vein, which is caused by surgery or severe muscle injury, increased estrogen, which is often caused by birth control pills, by hormone replacement therapy, or by pregnancy, or if the child has chronic medical conditions such as cancer, lung disorders, kidney diseases, inflammatory bowel diseases such as Crohn's, or obesity. Age is the biggest risk factor, and the risk increases with age. So the older you are, the more the risk, that's why we see clots more commonly as we age in the 60s, 70s, and 80s. What is thrombophilia? Thrombophilia is a term that we use that denotes a predisposition to form a clot inappropriately. And this predisposition can be acquired where there are clinical risk factors that we just saw in the earlier slide, or these can be genetic. In children, the most important causes of blood clots are acquired, which is either clinical or iatrogenic. Some of the less common causes of blood clots are genetic causes, and these include some mutations in factor V Larin gene or the prothrombin gene, or it can be because of decreases in naturally occurring anti-clotting proteins, such as the protein C, protein S, or antithrombin, which are normally made by our liver. In our clinical practice, the only time that we consider thrombophilia testing for genetic factors are when there is spontaneous thrombosis, meaning clots occur without any identifiable provoking risk factors. In those circumstances, we test for the genetic factors that I just listed, as well as there are some other acquired risk factors like antiphospholipid antibodies or lupus anticoagulant. We do not recommend thrombophilia testing where the clot is because of a known provoking risk factor, which were some of the reasons that we saw in the earlier slide. We also currently do not recommend testing of unaffected siblings. So if there is a known genetic thrombophilia identified in the family, we do not recommend that their siblings get tested. We do counseling for unaffected siblings through our clinics. We discuss what is the appropriate timing of the testing, what is the relevance of screening, and then do counseling for future high-risk scenarios. We also do not test asymptomatic children prior to high-risk clinical situations routinely, such as cancer, or if they're considering the combined oral contraceptive pills containing estrogen. If we find on our testing that a genetic thrombophilia is present, then we share what our current views are. We counsel regarding risk factors that can be additive to the already existing genetic thrombophilia, and we advise if oral contraception is appropriate or not in that scenario. How do we treat blood clots in children? It's by these three common agents that you see listed here on the slide. Usually the first agent, heparin, is the most commonly used agent. It's present in both the intravenous and the subcutaneous form. The intravenous form is used primarily in the hospital setting, and then the subcutaneous heparin can be used when the children get discharged from the hospital. If the child needs treatment for longer periods of time, then obviously we want to avoid the subcutaneous injections, and they usually get transitioned over to the oral blood thinner called warfarin. There are some newer oral agents that have gained regulatory approval, and rivaroxaban and dabigatran are the two agents that are currently approved for use in children. Commonly, our first go-to agent for treatment of blood clots is heparin. If they need slightly longer, we consider an oral option, which can be either warfarin or those two oral agents, depending on what the clinical context is for them to get a blood clot. Although we refer to anticoagulants very commonly as blood thinners, it's sort of a misnomer, meaning that they don't really thin the blood, but they make the blood more difficult to form a blood clot. Some of the common precautions we discuss with families when the children are ready to be discharged or on an ambulatory setting is that the common side effects, we ask them to look out for are nosebleeds that can occur frequently or last longer on an anticoagulant, bruises in areas of injury, and then for teenage girls and young women, we counsel them talk to them that the periods could get heavier whilst they are on treatment. If they have any of these signs and symptoms and they're occurring for longer periods of times, or it's causing them problems, we do ask them to seek prompt medical care. We do want children to stay active even when they are on anticoagulants. So our general recommendations for children on anticoagulants is that we encourage them to continue regular exercise or gym in school. We do review some age-appropriate and supervise low-impact, low-injury risk sports such as walking and swimming and biking. We allow children to engage in those activities. And we also share with them this list of sports that you can see listed as low risk, low to moderate risk, and moderate to high risk. We definitely counsel them against pursuing any sports that are moderate risk or high risk because they can be prone to excessive bleeding. Some of the complications that we see with blood clot include loss of organ or limb, especially with large venous blood clots or clots that occur within the arterial system. One of the other complications that we see is a condition called post-thrombotic syndrome. And you can see that in the picture on the right lower hand corner, where the right leg is swollen in comparison to the other leg. It shows all of these, what we call as venous collaterals, which are dilated veins because of damage to the valve. And that leads to venous stasis and chronic skin ulceration. And this happens in a small number of children, thankfully. Post-thrombotic syndrome can affect up to a third of children with blood clots. It can also cause, rarely, a condition called chronic pulmonary hypertension with clots in the lungs. Very, very rarely, it can cause death. VT can also complicate management of the underlying illness. For example, if we see blood clots in some common inflammatory conditions such as cancer or lupus, it can also obviously increase length of stay and hospitalization costs. We share some prevention and useful tips after children complete treatment for a blood clot. For future, we do advise that they move around as soon as possible after surgery, illness, or injury to prevent any stasis. If they are traveling either in the car or an airplane for more than 4 hours, we advise that they get up and walk around. If they can't, we ask them to do some leg exercises. Hydration is a very useful prevention tip, drinking plenty of water and avoiding alcohol or caffeine. Regular exercise, maintaining a healthy weight, to avoid smoking. And we also advise that if they have a family history of blood clots, to please talk to the primary care doctor. The best treatment for children with blood clots is a team approach. And we do that through our thrombosis clinics. The team usually includes a hematologist who is well-versed with treatment of blood clots in children. It also includes a nurse practitioner or nurse coordinator, physical therapist, a genetic counselor, and social worker who works closely with the patient and the family, as well as the primary care provider. These are some great educational resources that are available for both families as well as general practitioners to get more information on the etiology and the treatment of blood clots. And these include the National Blood Clot Alliance, Vascular Cures, and Clot Connect. So in summary, venous thromboembolism is a multifactorial disease where both clinical and genetic thrombophilia contribute to VT development. Routine thrombophilia testing is not advised in all children with VTE, and we do a careful selection of those children who might benefit from it. There are large national and international societies and clinical trials that provide guidance on duration of treatment of blood clots in children. And research in children will help us understand safe and effective ways to prevent blood clots in children. And with that, I will stop here, and I'm happy to take any questions, Chad, that you see.
Well, thank you, Dr. Bhat. That was an outstanding presentation. While we let questions gather, I have a few for you. So I was really happy to see the breakdown of the clinic and see how many people you have, whether it's a genetic counselor or APN. So thank you for going through your clinic. What I would like to know is, where are the clinics? So where do we have our clinics?
Because of the multidisciplinary care that we provide for our children, our clinics are primarily at the downtown location here at Lurie Children's in the Chicago campus area.
Okay.
So although I do go out to the other satellite clinics that you just showed earlier on during the introduction.
Mm-hmm.
We actually avoid trying to do that because there are multiple providers that are needed in order to take care of these children.
Okay. And could this be an EPIC referral, or how do our PCPs in the area refer in for this clinic?
So usually it's a referral base. So they refer either through the central schedule. So the central scheduling office gets these referrals from pediatricians, or they come directly to our division, and then our schedulers take care of those referrals. As part of our team, we have 2 excellent nurse practitioners that then either look at the referrals, make sure that there is a reason for seeing the child, or there are different other avenues where a patient or family can self-schedule in through a decision tree.
Okay. You know, one of the things you brought up earlier was predisposition with families. So, you know, we do a lot of these talks with our community physicians, and one of the things we talk about is, we try to convey, is the importance of communication with the families and the PCPs. So, so whether it's previous cancers or blood clots in the families, it's got to be really important for the engagement, I would assume, not only between you guys and the PCPs, but the families and the PCPs, I would assume, right?
That's correct, yes. So we have several ways where we communicate. One is obviously through written communications to the primary care doctor once we see them in clinic. We also, a lot of pediatricians' common questions that they have is about, you know, sports and other activities, what they can allow, because they frequently come for school physicals.
Right.
They have to sign off on forms for sports participation. Some of the other questions we get are also related to oral contraceptive use.
Okay. Well, I don't see any other questions coming in. So we're going to go ahead and close out our session with, first of all, thanking you, Dr. Bhat, and then thanking the audience for joining us today. I want to remind our audience and those who are watching the recording that any referral information for Lurie Children's is always available at luriechildrens.org/physician services, and we have all your referral information right there, whether it's our outpatient center or provider schedules and all their locations, phone numbers, patient referral forms, laboratory requisitions, you name it, it's right there. For those of you who are QR code savvy, just go ahead and scan that right there. And for those of you who are enjoying our roundtable presentations, especially this one here in our 6th session, hematology and oncology, blood disorders roundtable. This is a full playlist that we'll have in our YouTube channel. So if you enjoy these, please hit subscribe, and you'll be able to get notices whenever we load any of our sessions. But that's it for us for today. Dr. Bhat, thank you for joining us. You were wonderful.
Thank you. Have a good day, everyone. Bye.
Have a wonderful day.